Hi, Chris.
Good afternoon, everyone. Welcome to another in the SMFM Fellow Lecture Series lectures. Again, this lecture today is one of the series of research lectures, and the organizers have put together a great series of lectures to provide some of the basic information on research that's important as you continue along your fellowship. It is my pleasure today to introduce Dr. Sean Blackwell. If you don't know Dr. Blackwell, among all of his many clinical duties, he's currently the director of the Larry C. Gilstrap Center for Perinatal and Women's Health Research at UT Health Medical School, and serves as the vice chair for clinical research in the Department of Obstetrics and Gynecology, and as assistant dean for healthcare quality and perinatal medicine and women's health at UT Health Medical School. He serves on several editorial boards and is a contributing editor for many of our journals, as well as a long, successful publication career and lots of work for Society for Maternal-Fetal Medicine. Today, he's going to talk to us about case control studies. Again, at the end of the lecture, there'll be ample opportunity for question and answers for Dr. Blackwell. You can type those questions in the question and answer tab, or indicate that you have a question by raising your hand, and we'll call on you, and you can ask your question live. Dr. Blackwell, thanks very much for joining us today, and I'll turn it over to you.
All right, thank you, Bill. I want to thank Bill and Chris for setting everything up, and thank SMFM for the invitation. I have the joy and privilege to talk about a very exciting research topic, case control study designs. I'm going to give a very bread and butter, straightforward approach, because I do think this is one of the areas where I think it's really important to go back to the basics and kind of have almost a drudgery, methodical, Rain Man approach to performing these studies right. Case control studies are one of the, it's a study design that is used quite frequently, and it's an area where we can go wrong if we don't stick to basic principles. So I'm going to talk a little bit about definitions. I'm going to talk about the situations where you would choose to do a case control design, because that's just as important as how to do it. I'm going to talk about some of the strengths and limitations of the case control design, and I do think it's really important when you write your manuscripts or publications that involve this type of study design, you do a thorough job in your discussion section talking about the limitations and the role. I'm going to talk about a few pearls related to study design that I think may be useful, and then talk a little bit about analysis and presentation of data, specific again to case control designs. There are, before I get into things, I do want to mention, there is the series in the Lancet that David Grimes, Ken Schultz have done on different study designs. Whenever I'm mentoring a fellow or myself doing a case control study, I like to go back to one of these reviews. This one I think was published in 2005 in the Lancet. It's a very good, quick read that you might find useful, and a nice refresher as you embark on performing a case control study. So the majority of case control studies are retrospective, meaning you're looking backwards. You are investigating from an observed effect or outcome of a case, going backward in time to look at possible causes, which would be the exposures. And then you're comparing the frequency of exposures among cases to the frequency of exposure among controls. Again, I think it's really important to use start out with a Sesame Street approach and build up from there. Case control designs, as defined, the majority are retrospective. You have one group of subjects with the disease and another without it. You try to look backwards to find differences in predictive variables or exposures. And then the concept is to explain or better interrogate or test hypotheses about those that got the disease or the outcome and those that did not. You will sometimes hear about nested case control studies. Nested case control study is a type of case control study. You will oftentimes see these as secondary analyses out of large randomized controlled trials or large observational data sets. It compares the incident cases nested within a singular cohort with controls also within that cohort, either drawn at random or in some other methodology. It is, if you are getting your cases in your controls from an existing registry or data set, it decreases some of the bias. It saves money because you may have collected a lot of other exposures or factors as part of the primary trial or as part of a registry. And some of these things could be quite expensive, such as biological markers, imaging studies, or that type of data. It also allows you to, again, if that cohort is large enough, to be able to have a large number of controls. So this is sort of the pathway for a nested case control. You know, again, you're measuring your outcome to distinguish cases from controls, and then your predictive variables. So in the big picture, a case control is really pretty simple. You define and so first you have to define your research question, then you define and select your cases, define and select your controls, and then you measure and compare your predictive variables between those. But let's get into the details a little bit. One of the fundamental, most important things in a case control study, and in any study design for that matter, is just to recognize the question that you can and can't answer. In a case control study, you are asking, is the prevalence of an exposure in the cases different from the prevalence of exposure in a control? And this is contrasted against the typical questions of a cohort study, which is the incidence of disease in an exposed group different from the incidence of a disease in an unexposed group? Again, I think it's really important to write out your research question as part of your analysis plan before you start digging into your data, and certainly before you start reviewing charts or doing other sorts of things. So let's pause and say, when and why should you do a case control study? What's their role within the spectrum of the medical literature and the research that we're doing? And why, if you're a first-year fellow with limited time, money, expertise, access to data, why would you spend her or his effort on this particular design versus being in the lab, versus trying to do a randomized controlled trial, versus trying to do something else? Why would you invest this effort here? You need to remember that there is a hierarchy of the levels of evidence. Again, these aren't written in stone. You certainly can have a randomized controlled trial that is of low quality and therefore has less contribution. But in general terms, in the pyramid, the case control study is number 4 on this list, and you need to put it into the appropriate context. So what is your question, as I mentioned before? Why you should do a case control study is if you're studying rare outcomes. If you were going to try to do a randomized controlled trial, or you were going to try to do a prospective cohort study of things that are rare, it's going to take you a long time. It's going to involve lots of effort, multi-center approaches, a huge amount of infrastructure, which may be prohibitive. A case control allows a relatively rapid, a high yield of information for relatively few cases. You can study more than one risk factor at once, and it can be hypothesis generating, which if you have a positive association with your case control, you may then invest your time and effort to go to a different type of study design and pursue that line of investigation. But if you don't find a positive association, that might answer the question and you go on and evaluate other things. In theory, case control studies can address questions on therapy, etiology or harm, prognosis, and prevention. Again, you want to match your study design to the you want to be able to match your study design to the type of questions that you're trying to ask. So case control studies, if you have access to a single center of data, a large registry, or if reviewing a huge number of charts is overly challenging, it can be time and cost effective to do this approach. So there have been case control studies that have had important contributions to our medical literature. One of the initial studies that described the association between maternal DES exposure and vaginal cancer in offspring was a case control study. One of the initial studies that started an investigation between sleeping positions or newborn sleeping positions and sudden infant death syndrome was a case control. So there is certainly a role for this study design in our field. If you're studying rare outcomes, and I just picked 4 outcomes, again, you may need to consider a case control design, hypoxic ischemic encephalopathy, class F diabetes, monochorionic twins with demise of one co-twin, maternal amniotic fluid emboli. These were all rare enough outcomes that other study designs may be prohibitive to be able to interrogate research questions about these conditions. Again, I think one of the most important things that you're going to do when you embark on a given research plan is that you need to understand what are the limitations of what your study design will allow you to do and what you can and can't do. Remember, with a case control design, you can really only study one outcome at a time. With other study designs, you may be able to look at multiple outcomes. Because of the nature of the design and it's not an assessment over time, there's no way to measure the incidence or the prevalence of a disease. Your relative risk can only be estimated, and it can't be established directly. You can't measure the attributable or excess risk. And it's, as I mentioned, it's difficult to establish any temporal relationships. And finally, which is probably the major limitation, is the susceptibility of case control studies to bias, and we'll talk about some of those elements of bias. So I think this is the #1 pearl that I could ever give a fellow as she or he is embarking on a given research project, is before you decide on what it is that you're going to do, before you do a single case review form, submit something to the IRB, review charts, you should define your question. This is fundamentally one of the things that I think people skip by. I think that this is one of the things that that people wish they had thought about this up front, but to really spend time on their PICO question, their population, their intervention, prognostic factor or exposure, the comparator, and then the outcome. Really spending some time going back and forth again and again, sharing this with mentors or other collaborators to make sure that it makes sense, that everybody's on the same page. You don't want to do this when you're 3/4 done with your project. That doesn't make any sense. You want to do this up front as part of your primary analysis plan. I would tell you your PICO format or your PICO question is just as important for your study as writing specific aims are for a grant application. You want to be meticulous and make sure that it's as optimized as you can. There's never going to be a perfect study, especially there's definitely not going to be a perfect case control study, but you want to optimize it to the best that you can to make whatever it is that you're doing the most rigorous analysis that you can do. Again, spend a lot of time vetting your question. Is it an important question? Does it match case control design? You want to define your cases. There are certainly some outcomes that are more amenable to a case control design. Outcomes or cases that are very discrete, that are very well defined, that don't overlap with other conditions, that don't get better or worse over time. Those are probably better cases. And then you want to spend a lot of time thinking about controls, the most appropriate controls for the population that you're studying. So in review, and there have been several surveys of case control studies done in the medical literature, a few in OBGYN studies and some outside in other specialties. And this was one of the areas where it was the most common reason for a fatal flaw was it was a choice of an inappropriate control population. And again, this is another area where you really want to think hard, talk with your mentors and or co-investigators to make sure that you've defined what's the right or best population before you review a single chart. So cases. You want to rigorously define, either you want them to be diagnosed or defined as strict as you can. Again, depending on what you're going to do. If you're using an existing registry, you obviously have to default to the definitions used in that primary study. But if you are creating a case control study where you're going to go out and ascertain cases and controls from medical records, then you want to do this up front. You want to also have some way to validate, that you've not misclassified controls as cases, and you want to have as much objective criteria as you can. And you want it to be as homogeneous as possible, ideally only a single well-defined disease. Your controls, you want them to be as similar to your cases as possible, except having the disease. That means that the controls are selected in a similar manner to cases. If you're using hospitalized cases, you want to use hospitalized controls. You don't want to use controls of people that are in the general population or that are presenting to clinics, because there's certainly some bias that people that go to the hospital or go to a clinic are going to be sicker to a general population. If you're going to take cases from the population, that implies that you want to use population controls. And as I mentioned, the nested case control study, you're going to take your controls from the overall cohort that you have available to you. So how do you choose controls to limit bias? There are multiple ways to do this, and ultimately there is not one right answer. Ultimately there is not a perfect way, because you have to balance feasibility along with a methodologic rigor. Certainly if you have an existing cohort, you may be able to randomly select controls. If you are looking at an outcome within the hospital, such as you're going to look at your cases are going to be a brachial plexus impairment, you could potentially look at your control is the next delivery, or you could find some other approach. And again, you want to try to have some quality assurance to ensure that the control does not have the disease, whether you're doing some sort of more detailed chart review or some sort of other structured analysis to minimize the potential that controls are actually cases. So one of the other things that you can do if you're really concerned about the similarity of your cases and controls is that you may need to do some matching on things that are important. Obviously, if you're going to do a study on pregnant women, your population that you're going to want to study is going to be pregnant women. But you may want to match based on socioeconomic status, smoking, race, maternal age. There may be rationale for doing that. And again, you want to think ahead of time, what are the pros and cons? Now, matching has some positives and it has some negatives. It reduces differences between the cases and controls and then can increase power. But there can be suboptimal aspects. If you match on a factor that's associated with the exposure, it's certainly going to be harder to find differences between the groups. If you overmatch, meaning you match on too many variables, you may either lose power or have a false reduction in your odds ratio, again, depending on how you analyze things. And then if you match on a given factor, you can't really investigate or study that factor as its association towards the outcomes of interest. So other aspects, bias. This is probably the area where when I'm mentoring our fellows or residents or other junior faculty, we try to walk through and say, okay, what are the things that we can do to minimize bias? There's sampling bias, recall bias, and then there's aspect towards confounding your interaction. And I'll touch base on all of these because they are relevant to the study design. So sampling bias. When you're looking at your cases, certainly you can miss some of these cases. There are some cases, again, depending on what's the population that you're studying, maybe the case doesn't medical attention. Maybe the case goes somewhere else. Maybe there was a misdiagnosis and the case was missed, or there was death or remission before you had the opportunity to make the diagnosis of the case. So there are certainly sampling biases that can occur on the case side. So there are sampling biases on the control side. So as I mentioned before, if your cases are coming from a certain location or subpopulation, you want your controls to come from that same location. If it's a clinic, a hospital, a population, again, population-based samples are good if you're doing population assessment. There are some opportunities to use more than one control group. Again, this is getting a little bit more sophisticated, but there are some rare circumstances with certain disease states or certain conditions where in order to, I'll just use cover your bases about the potential for bias, you can use more than one control group. And then you can use matching as I described before. This is a figure that comes from the David Grimes and Ken Schultz review that I mentioned up front. This is, you have multiple options for deciding what your where your controls are going to come from. Known groups, you can look at, do things at random. You can do random digit dilating. You can come up with some mechanism of the next patient. If it's unknown groups, you have other options. Again, these are things that you probably really want to spend some time thinking about before you embark and review a single chart. Recall bias. This is a big deal in case control studies. So recall bias is a diagnosis that results in reporting of exposures differently than controls of people that don't have the disease. It's just common sense. If you have a diagnosis and you have an abnormality, oftentimes we spend more time getting more detailed histories. We document things differently. Patients may provide history differently, and if you're a control, you may not have that same level of reporting or information. This can happen both if the associations are known or if the association is not known. And then you have to remember, if you're using medical records and charts, many of these exposures or factors are not adequately documented in the medical record, and there are some things that you can, but I wouldn't universally say. But I would be very cautious to say that something is a negative exposure if it's not mentioned in the medical records. I don't think that is a sound approach. So what can you do to decrease recall or measurement bias? There are some things that you can do, although it's a little bit harder. You could use data recorded before the final outcome occurred, so therefore the diagnosis of that case wouldn't potentially affect the documentation of the information before that. You can use a nested case control design where you've got a large cohort where you've already got all of those explanatory variables or exposures documented, in the entire population. In theory, that you could do some blinding with your ascertainment of your data. If you're getting your data from interviews, certainly you could blind that ascertainment from the people that are collecting the data. It is, I would say, it's difficult to blind a diagnosis in the majority of case control studies, but certainly other information you could potentially abstract from charts where the abstractors would be unaware of the case or control. If you're looking at collecting information on X-ray information, blood testing, other results, certainly it's feasible that the people collecting that data and recording it in your case review forms could be blinded to the case versus control status. So confounding. Confounding is something that you should definitely be aware of in the study design. It's the mixing of effects in which a risk factor for the disease is associated with the exposure being investigated, and it typically exaggerates your odds ratio. Again, I think this is where you have to be thoughtful in the variables that you're assessing, and this is where your clinical sense lends greater expertise to your analysis. So things that confounding can be avoided only when the possible confounder is suspected and measured. Again, you can do matching, you can do specification, exclusion, or restrictions of certain patients, and you could potentially use adjustments in the analysis. And then stratified or adjusted analyses can identify confounding if you have age or race or other things that may affect and be one of these variables. You can stratify with that. Here are going to be some slides of a tool that I commonly use when I am doing a manuscript review of a case control study, or when I'm working with one of our fellows or junior investigators and I'm trying to assess, did we check all the boxes in our methodologic rigor for a case control study? It's a checklist. This comes from CASP, and I find it to be very useful. And there are these tools for all the study designs, and they're widely available on the internet. So again, are the cases defined precisely? Was there a reliable system for selecting the cases? Is there something special about the cases? The time frame? Was a sufficient number selected? Was there adequate power? Again, these are the things that your reviewers are doing mentally as they evaluate your finished product. There's same set questions for your controls. Were the controls representative of a defined population? Was there matching? Was there sufficient number of controls? These are all questions, again, that you want to look as you're going forward. And then specific questions about bias. Did they use subjective or objective measurements? Do the measures truly reflect what they're supposed to measure? Were they similar? Were the measurements similar in case and controls? Was there blinding where feasible? Was there a temporal relation able to be adjusted or able to be interrogated? Again, these are questions that your reviewers will be asking as they evaluate your work in this type of paper. I think here, have they taken into account all the potential confounding factors in the design or in their analysis? This is, again, an area where I think it's very important, at least I find it important, in an author's discussion section when they're doing this type of observational study to talk about known and the potential for unknown confounders and the limitation of this study design. So let's talk about data analysis. A data analysis for a case control study, we use, most people use a 2x2 table. On the upper proportion, you've got cases and controls. Your cases are A and C. Your controls are B and D. And then on your left-hand side, you've got exposed and not exposed. And then with case control studies, the majority of the time you're assessing an odds ratio. Just as a matter of reminder, an odds ratio is the ratio of the odds of exposure in the cases related to the odds of exposure in the controls. This type of study, again, gets back to hypothesis testing, and then you're going to use your chi-square or your Fisher exact, depending on what's the number of numbers that you have in your 2x2 table. Just as another refresher, probability and odds, these are things that, again, are very easy to get confused, and when you are writing or describing your manuscripts, you want to have this clear in the way you numerically represent and explain your data. So your probability is the number of subjects who experience an event divided by the total at risk for the event, and your odds are your probability of an event divided by 1 minus that probability equals the number of times an event occurred divided by the number of times it did not occur. So just some general examples. If you have a probability of 50%, your odds ratio is 1. If you have a probability of 80%, your odds ratio is going to be 4. If you have a probability of 33%, your odds are 0.5. And a probability of 5%, it's going to be an odds ratio of 0.05. Again, these are things that it's very common for all of us to pause, have to think through this, and explain it to ourselves, say it in your head, and then go back and utilize it. Again, odds ratios are what we use in case control studies. It's an estimate of the risk when the outcome is rare. The lower the risk, the more closely the odds ratio estimates the risk ratio. The odds ratio is always further from unity than your relative risk. But again, you're going to use odds ratios in your case control designs. So a small number of subjects will result in an unstable estimate. You want to use 95% confidence intervals for your odds ratios, just as for anything else, because this will help give you information about the certainty of the odds ratios and the effects that you're studying. So when you're doing your analysis, you certainly can involve multiple confounders to be controlled simultaneously. You can utilize continuous variables when you want, but you have to remember that your model may not fit the data well. You can have incomplete control of your confounding. You can have inaccurate estimates of your odds ratio. You want to assess the fit of your model when you're doing your analysis. It's not just about your odds ratio and your p-values. So again, this is something that you want to think up front. This is how many subjects do I need, or how many cases do I need matched with how many controls to have a meaningful assessment of looking for differences in these two groups. What's a clinically significant, or what's a scientifically meaningful odds ratio that's worth detecting? Again, this is what you should do up front. And then you also need to have some understanding of the exposures that you're really interested in. What's the probability of this occurring in your control population? Again, you want to do a sample size calculation and a power analysis up front so that you decide how many cases and controls that you need, and then what's your number of cases to controls. So again, this is my CASP tool that I use. What are the results of the study? What's the bottom line? Are the results adjusted for confounding, and might confounding still explain the association? Has adjustment made a difference to the odds ratios? How precise are the results? How precise are the estimates of risk? These are the things that your reviewers are going to think and ask about as they look at your results section. So I think, again, the other area where I think that we can sometimes go overboard is that we can overinterpret a case control study. Association does not determine causation, and we need to be cognizant of the limitation of a case control study. If you want to evaluate causation, there's the Bradford-Hill criteria, and you want to think of other things that go along with this. Temporality, dose response, consistency of association, biological plausibility. That's the role of these other things as well, not a singular association from your logistic regression. So to summarize, case control design, it's ideal for studying rare conditions such as HIE, AFE, maternal death. It's meant to evaluate exploratory hypotheses. It's not meant to be the final study. If you find associations that you think are positive, then you go on to the next design and to a next study. The strengths are it's relatively time and cost effective. The weaknesses are the things I mentioned: subject to bias, you don't get incidence or prevalence of the disease, you don't have a temporal relationship, and you can't necessarily directly measure your trivial or excess risk. The three things that I think are my final pearls are: number one, vet your research question. Whether it's a case control study or whether a design or something else, make sure your PICO question or your research question is tight. Next is rigorously define your cases in your control and make them as homogeneous as possible. And then be aware and describe the limitations in your conclusions regarding the study design and the role that a case control plays, emphasizing that it's hypothesis driven or hypothesis generating, and making sure that you're not overreaching with your conclusions, to me are very important if you want to have a case control study design published in an impactful journal. I think those are things that are key. So with that, Bill, I'm all done. I want to thank people for their attention and the opportunity to participate in this, and I'm more than happy to answer any questions. Because at UT Houston we have access to like the maternal-fetal medicine units network registries, because we're part of the network, they're more likely to do case control studies or nested case controls. So there's at least one or two fellows at a time doing this type of design. I think the things that you get out of it, you're not going to find the solution to preeclampsia doing a case control study, but you are learning how to do analysis, to be methodologically rigorous. You're learning how to do research and to write papers, and to go through those steps as you go on your journey to more sophisticated designs or other aspects. It also allows somebody to learn a lot about a given condition. By nature of doing research on a rare condition, you're going to learn a lot more about that condition. So I think there's definitely some benefits. I would urge people not to spend all of their research time and effort on a case control design, but I think that there's a lot of benefit in doing them. Yeah, I mean, I think with SMFM abstract deadlines and the ready availability of vitality data sets, and looking for things that are novel, we sometimes can just start exploring, and looking for associations as opposed to, kind of doing things the right way up front and then pursuing it. This is probably another area where there's a lot of publication bias, where if you're doing a case control study and you find an association, it's much more likely that people are going to be enthusiastic to go on and publish it, as opposed to, or present or publish it, as opposed to doing case control studies and not finding associations. Well, Bill, I must have solved the riddle of case control studies, which is perfectly fine with me. My pleasure. Thank you all. Thanks again, Bill and Chris.